Welcome to the Living Medicine Podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hi, everybody. It's Sandy Newis of the Living Medicine Institute. And as I'm sure you know by now, we are a business providing resources and training and content for clinical and medical providers who are interested in psychedelic-assisted psychotherapy with a specific focus on ketamine-assisted psychotherapy. And I am delighted today to have Jim Hopper here. So thank you so much, Jim, for being here. I really appreciate it.
Great to be here, Sandy. Good to see you.
Yeah, nice to see you too. So, I just by way of introduction, and then I'll let Jim say a little bit more about himself. I actually met Jim, I believe, although I might have read something somewhere, at the psychedelic assisted psychotherapy conference, which I'll just put in a shameless plug for, which is a great conference. And I just came back from there a week and a half ago. And, Jim, I heard you present there and was immediately impressed by the way in which you were merging psychological theory and intervention that was recognizable from psychotherapy and clinical psych and counseling psych into the psychedelic world. And that's something that really stood out to me because we've got a lot of researchers who talk, and none of that is wrong. That's lovely. But it was really clear to me that that you were articulating really well, kind of a grasp of the clinical process. And so, I've been following you ever since. And we're going to reference a talk that you gave to Phil Wolfson's group, the Ketamine Psychotherapy Associates group. That was great.
Mhm.
And so, yeah. So, what else would you like to say to yourself? Say to our listeners to introduce yourself.
Yeah, I'm a clinical psychologist by training, and I'm almost 60 now, and since the early 90s, I've been pretty immersed in the trauma world. You know, some time spent with Judith Herman and being mentored by her and her organization. And I used to run Bessel van der Kolk's lab for a number of years. And just being here in the Boston area, it's kind of a mecca of trauma people in a
There's
way. And so,
trauma
I,
incubator.
yeah, so I've just been really fortunate to have great colleagues and mentors here and to learn a lot about how to do clinical work with complex trauma, and so that's a big part of where I'm coming from. And I was a therapist in the MDMA trials for PTSD, the MAP studies, and so that was when I really started getting into the psychedelic work. I don't do any underground work, so I was a therapist in that study, and I've been working with ketamine since 2020.
Mhm.
So those are some main things about me, and I bring different backgrounds to it. So I've done research, I've done neurobiology research, I've done research on memory, I've focused on male sexual abuse victims and their capacities for healing and what supports them, and so I've kind of dabbled in a bunch of different things, I could say, I guess.
Mhm.
Yeah.
Well, and you mentioned in a previous conversation you do some expert witness work. I don't know if that's kind of, in those broad domains, just to give it kind of the broadest context of all about what you do in the world.
Sure. Yeah. So I do a lot of teaching for police and prosecutors around the country and around the world.
Mhm.
And I translate neuroscience for them to help them empathize with sexual assault victims and see how they're not so different from them and how evolution shaped their brains to respond to being attacked, whether that's sexually assaulted or being shot at as a police officer or a soldier. And I help them think about why people don't fight or yell, why their memories can be fragmented. And so I translate neuroscience and I draw these parallels between the lived experience of police and soldiers and those of sexual assault survivors, to help them basically do better by survivors when they're in the legal system.
Yeah.
And so that's a big part of what I do. And then I do expert testimony in
Nice.
sexual assault cases where I educate the jury about these things. So that's an area where I have more influence in the world than the psychotherapy world. But I love both worlds. So, but that's part of what I do as well.
Well, but it's interesting because I think when you start to get into, thinking about everything through the trauma lens of which I, share, at that point, we're looking at the brain and the nervous system and, relational manifestations and how things show up in relationship. And, so at that point, to me anyway, the lines between what is and is not therapy become blurry. like, I mean, we've got, of course, the session, but then there's all of the different other components of it too. So yeah. So here's the $1 million question then. So you're working in trauma, and then did like, the MAPS thing just appear? Did you like, was that like the next logical step? Is that like, how did you kind of make the leap from, I know many people have done it. I mean,
Yeah.
you're not the only one, especially in Boston, but how'd you make the leap into psychedelic assisted psychotherapy? Was it a mission for you? Did it just appear? Were you just
Mm,
interested?
yeah. So as a young person, I had some psychedelic experiences in late high school and in early college. And part of that was uh, basically I had a vision of doing this work at some point
Mhm.
at age 20. And but I also had a recognition even at that young age that I was not it was going to take me a while. There was a lot of work I had to do on myself to really be in a position to be a therapist in that role. And I also could see that the culture wasn't ready and might not be for a long time. So that was part of it. So I had kind of this vision of doing the work, but I knew I needed to do a lot of work on myself first. Um, and I had that experience with MDMA as well. There was, tapping into all this love and compassion, and then realizing like, wow, I'm gonna have to do a lot of work on myself to get even close to being that loving,
Right.
in my daily life and relationships. As a 20-year-old male, I had to. It was, some grief there, realizing like, wow, I got a lot of work to do. So then, fast forward 30 years later, I was part of a group with Bessel van der Kolk and some others, and I heard, and I had been following the MAPS work. Even
Yeah.
back in '98, I saw their protocol, and I could tell like, wow, these guys really know like PTSD outcome research, and it sounds clinically really good. So when I heard that there was going to be a phase 3 trial and there was going to be a Boston site, I was
Mhm.
like, oh wow, maybe it's time. So
Right.
then I reached out to Rick Doblin, and then I became a therapist in this study. So that's kind of
Uh-huh. I
the
love it.
backstory on that.
Oh, interesting. Yes, I was another person who heard that call and was like, I'm going to do this work at some point when the moment
Yeah,
is right. Right. The
yeah,
moment meaning myself, the moment meaning regulatory, the moment meaning culture, when those things line up. So
yeah,
yeah. Yeah. Great. So let's kind of go to this trauma piece, right? Like it permeates so much of what you're talking about. And I consistently hear you talk about trauma-informed care tenets as a basis for this work and the importance of relationship and attending to the therapeutic relationship and, solid psychotherapy principles. And I know that that might seem obvious to you. It's just that, we have a lot of people kind of entering into this field who think a lot of that the medicine, is what does the work. That it's the medicine that does the healing. And what I appreciate about you, I think, I mean, I'll let you speak to it, but is that it is the blending, it's the use of the medicine, but that we're really doing psychotherapy and we're really even more specifically doing trauma focused or trauma informed psychotherapy. And I just love to hear kind of, what do you mean by that? Um,
yeah.
when you say let's use trauma informed care and trauma informed tenants, what does that actually mean?
Yeah, so there's a lot we could say about that, but there's a couple like fundamental principles that I think are really important. And again, Judith Herman articulated these way back in the early '90s, that good trauma treatment, as well as supporting people to seek justice, involves connecting, genuinely connecting with traumatized people and empowering them. And those two principles are just so at the heart of this work. And they're the antithesis of what it's like to be abused by other people, to be dominated and exploited and harmed, through physical abuse, emotional abuse, sexual assault. So good trauma treatment does the opposite of what a traumatizing relationship does to someone. And so those core principles of empowerment and connection are just really at the heart of it. And they're easy to say, but they're actually pretty profound things to try to embody
Right.
in relationship with our clients. And then, some other thoughts we can explore is, well, how is good trauma treatment good psychedelic treatment? We hear a lot of inner healing intelligence, and you know, to create the conditions for someone to access their inner healing intelligence, or at least increase the odds that they'll be able to do that. That involves genuinely connecting with people, empowering them through informed consent, through really making sure that they have autonomy to make decisions about how to progress forward through the preparation phase, to the medicine, what dose of the medicine, and all that. So, good trauma treatment is really about supporting people to access their own inner healing capacities. And that's at the heart of good psychedelic treatment is to the medicine plus the relationship and the set and the setting. These are about creating conditions that can enable people to access their own healing capacities.
Mm.
One way I think about it. And then I also think about how we can break down the supporting of empowering people, how we can think about different dimensions of that too. So we can get to that at some point if you'd like.
Oh, how about now? Right? Like,
Okay.
we're going to talk about, I actually just wrote it down. So, empowerment and connection. So, let's talk first about the empowerment because I really want to also kind of really separate that out and focus on the connection.
Yeah.
It's like you said, I mean, you said something just really important just a second ago. You're like, well, duh, like empowerment and connection, like, of course. But like people, what does that mean? And it's like, doing that with skill and with intention is a lot different than just being like, I feel empowered, to go out and make my own decisions. Like
Yeah.
it's a word that has like an imprecise meaning, in my opinion. So when you say that, like, not that we shouldn't use it, I'm just saying, but what do you mean by empowering a client? Like, and how do we do that in psychedelics?
Yeah. So one of the things that I've been influenced by is self-determination theory by Ed
Mhm.
Deci and Rich Ryan. I went to University of Rochester undergrad. They were professors that I know it's so funny in a psychedelic conversation where it's like, wait
Right.
a minute, even though I don't do underground
Underground means
work,
a whole different thing.
right? Right. Even though I don't do underground work, but so they talk about these three fundamental human needs of relatedness, autonomy, and competence.
Mhm.
And so when I think about empowering people, I think of it as having these two wings to it. And one is supporting their autonomy, their
Mhm.
their capacities and their experience of choosing freely how they want to proceed in the therapy, how they want to engage in the relationship. Again, what dose they or thinking could be good for them, all in consultation with me, of course, but really supporting people's autonomy because, again, that's the opposite. When someone is being abused by someone else, they're being treated as an object to be used, and their autonomy and their needs and their will is just not something the perpetrator is at all interested in. But then there's this other aspect of empowering people, which is supporting their competence.
Mhm.
So, we talk about strengths-based approaches, people's capacities for resilience. People come to therapy with competencies. Yes, they come with, limited skills and they come with some self-regulation deficits and things, but they also have their own competencies. And even some of their competencies can also be limitations. So some people are highly intelligent and it's a
Mhm.
competence of theirs to be able to analyze and think things through, but they can also get lost in their head, for example.
Mhm.
So when I think of empowering people, I think about, well, how do I support their autonomy, but also their competence?
Mhm.
And as we can talk about, there's risks that if we weigh too heavily on one side or another, that we can end up actually causing harm and disempowering them and even re-traumatizing them.
Mhm. Mhm. So say more about that. If we put too much emphasis on competency and autonomy, is that what I just heard? That we could
Or it's
end up
if we put
and
too much on
or.
one or the other.
Oh, okay. How would that be re-traumatizing?
Yeah. So one of the caricatures out there about the inner healing intelligence is that it's a therapist sitting over here and the client's over there, and you're just like, oh, just trust in your inner healing intelligence. And then the client actually may be lying down with eye shades on, and they may be like totally flooded with horrific trauma memories,
Yeah.
but they've gotten the message from you like, well, I'm supposed to be inside, trusting my inner healing
Mm.
intelligence.
I see what
And you can actually end up replicating abandonment dynamics that they experienced especially in childhood. So there's a way in which if we're overly confident and naively confident in the inner healing intelligence of the client, that we can actually be too we can hold back too much and they can be floundering over there and we're not tuned into that because we're so rose-colored glasses about inner healing intelligence. And this can definitely happen. I mean, we hear about people who've had this happen, who've had this experience. It's something that I've had case of in the role of the client of like, you know, does this person really, are they just, do they want to deal with me? Are they saying, go inside, Jim? Is it because they don't want to deal with me and I'm feeling
Sure.
abandoned? Or is it like, hey, that's what I really need to be doing right now? Or whatever it might be. So I've
Right.
experienced this, in the role of a client, as well as witnessed it, and heard my clients have these experiences. Now we've been able to catch them before they spiral out of control,
Mhm.
but I've also had people who've come to me who felt like they were really neglected and abandoned, in some of these relationships with underground guides or with
Right.
therapists. Um, and I think it is something that I have heard happening more in the underground where, it's not an ongoing therapy relationship. They might do one prep session and they don't really know them that well. And then the person comes
Mhm.
in, they feel totally overwhelmed and flooded. And the therapist the guide is like, well, you've got everything you need inside, trust in the
Yeah.
medicine, whatever, trust in your inner healing intelligence. And people can actually experience it as profoundly abandoning and re-traumatizing.
Wow. Yeah.
So I've heard these stories but I also have just seen this dynamic. I've experienced it in both roles. And so it's something I'm really sensitive to. So that's one possibility
Mhm.
in the wish to support people and empower them by believing in their inner healing intelligence, then we can end up having them feeling abandoned. So that's how that can go in an extreme direction.
Mhm.
Then can lead
Mhm.
to and then that can spiral if it's not noticed and repaired.
It's interesting that you say that, like that people just sitting back and, clients being given the impression that like, or even like people who are new to the field, or maybe those who've been in the field a really long time, just thinking that that means we just be with the client. Like, I mean, it's like there's a fundamental difference between being a sitter, and holding space for somebody and getting involved, in a more therapeutic way. I mean, I consider that to be one of the ways, the intentional use of your relationship and
Yeah.
creating
But
this
sometimes you think you're
connection.
holding space, and actually you come to learn later that the person felt like you had abandoned them.
Totally.
For
Right.
this episode. That's where it can go
Right.
wrong.
Yeah. I mean, we're aware and, like for us at Living Medicine Institute, like we advocate talking much of the time with the clients on ketamine, and not everybody feels that way. But that is part of that the client feel held, that they feel, I call it getting in the bubble, like that we're in the relationship with them. We're like in there with them, that it's not just them on their own journey and we're just like holding space to make sure they're okay. It's much different than that.
More relational than that. Yeah, and that can be through speaking with people, but it can also be very subtle, just how you're attending to them and tuning into their body and the signals, and it can be intuitive. Um,
Mhm.
but then there's
Mhm.
this other side where I think there's a risk of, especially from people who they have that intention and that concern that you do of you don't want people to be all alone in there and you want to be with them. Um, and then one of the ways that can go is, we want our clients to access certain inner strengths, or we want them to integrate certain capacities or strengthen certain competencies they might have or that might be emerging for them in terms of how they relate to their shame or to their bad memories or to whatever it might be. And so this is the other pole that I've seen is that
Mm,
therapists can get really enthusiastic about
mm,
what they have to offer this client, or they can think like, oh, well,
mm,
I'm supporting their inner healing intelligence by making sure they get this experience of their body, or making sure they get this AEDP intervention that's going to be so perfect right now, or something like that. And that this can then, in the zeal to make sure you're helping them and supporting their emerging competence, that
mm,
then you can end up dominating them and they can end up feeling exploited. They can end up feeling like you're on your healer trip and that's actually not what they needed. And it can feel intrusive, overwhelming. And so then the risk there is now you're getting into that dynamic, reenacting the ways others have dominated them and hurt them.
mm.
And
Well, I
so
think that's part of the issue, like where we start to put, which is another thing to get to, and later in this conversation, I mean to interrupt your flow, but
I was not going
I
to.
think it's part of the thing where if we're only doing one medicine session and viewing like that be the end all be all, like we've got to get there in this one session. Like I saw somebody today who was doing a lot of developmental trauma work, and I've got another session with them coming up. like at the end of this week. And so, we touched into it, but I know that it's a process. If I were doing traditional psychotherapy, I probably wouldn't like push them into that, like, and I think that's one of the dangers that we feel like everything has to happen in this medicine session, whether it be, you know, 1 hour on ketamine or whether it be, multiple hours on another medicine in a clinical trial. Like, and I think that's just one of the misnomers in the field that we have to do it on the medicine.
Yeah. And yeah, just that sense of urgency, like, and sometimes, this work can be expensive for people, like a 3-hour session, if they're paying full fee, that can be a thing that leads the therapist to really want to make sure they're helping them. But then it can go into this other territory. And I also think it's just we all have our different styles and limitations. Like, I think for me, I'm more likely to hold back, and for people to maybe feel like I'm not as in there with them as they might want sometimes. Whereas I have colleagues who I think they're more likely to go into the like, oh, got to make sure I do this, and then people to feel like, whoa, that's too
Mm.
much. And it's not to say there's anything wrong with us, but these are just poles that we can fall into, and we have our different personalities and our motivations and fears that can lead us to go in one direction or the other. And then if you add in the sense of like, oh, we got to do this now or whatever, then it can exacerbate these things.
Totally. Well, and for me, that it's been helpful to realize that that particular piece is also something I have felt in traditional psychotherapy, especially when I was newer in my career. Like,
Yeah.
I've got to be of value. I've got to prove that we've got to get there now so that they can really get what they're coming for, and not recognizing that the relational that can lead people to not feel safe. Either one, they're pushed, or two, but just to go land in like the place of attunement, like,
Yeah.
it takes us back to that relational piece about the importance of attunement.
Yeah. And so yeah, as you were saying, it can happen to people who are new and young as therapists. But then there's the other side, someone who's a very experienced therapist and they're so confident in their methods and everything, or maybe people get attached to a particular model.
Mhm.
And then you can overestimate, your knowledge of what they need right now and things like that. So, at any age, any level of experience,
It's
these
true.
are potential
I
pitfalls.
know what's right for you.
Yeah. And yeah, and while I totally appreciate the relational aspect, sometimes people do need a little more space, I think, and
Right?
don't need someone in there with them, talking to them the whole way through. But, who am I to say? Like, it's all different contexts and relationships and everything. But, that's something that I feel like I've seen too sometimes, is that
Oh, yeah.
the relational mode can actually lead people to relate to someone in a way that they're like, whoa, that's too much. I need more space here.
Mhm. Yeah, I've probably been guilty of that at times. Just
Well,
like
we all have our things,
right.
we all have our things, and some of us maybe go back and forth between these poles sometimes. It's
Mhm.
thing stuff,
Mhm.
it's therapy stuff. It's not just about the medicine sessions, but they can really supercharge it because of the vulnerability, the suggestibility, and the
Mm.
things that can get stirred up. So then these dynamics can get very powerful very
Great.
quickly.
Well, let's talk some more about that. So you talked about empowerment and connection, and then you talked about, that those being core tenets of trauma-informed care in this way.
Mm,
And then you also talked about the relational aspect. So we've been talking about the relational aspects, but
mm,
just kind of like, highlighting that about what you just said about the relational dynamics, and at that point we're talking about transference, we're talking about safety, but there's a lot of different things that that means. So can you say more what you mean by that? And, just with what you think we should all be attending to, really. I mean, that's a huge question,
yeah, that's a huge one.
wherever, and go from there.
Yeah, yeah, but some of the things that I think are, I was trained in the psychodynamic tradition, so there's a lot of attention. You use the word transference, there's a lot of attention to transference and countertransference and these relational dynamics and our vulnerability to reenacting early relationship patterns, with our clients, ones that were harmful. Um, and the need to recognize that and repair when it happens. So for me, like fundamental is really trying to be humble and honest with myself about like what might be getting triggered in me, what might my motivations be. Um, and so really attending to what's motivating me to relate to or even think about a client in certain ways. Obviously, you can't be meta obsessed with this stuff all the time, or you won't be connected.
Right.
But just try to have kind of this sense of like, checking in about like, well, what's my motivation here to say this, or the way I'm interpreting what they're doing. So a lot of it is, having self-awareness of, your own tendencies, your own vulnerabilities,
Mm.
that sort of thing. And then, if it's an ongoing relationship with a client, really learning from that relationship, and what are the dynamics that are happening, and how can you work with those skillfully? How sometimes do you need to step back and reflect on those together with the client? Those are some of the key things that I find helpful, but there's so much more we could say about it, but those are a few. Yeah.
Well, but I think as you say that, what grabbed my attention when I first heard you talk that way is, again, when we speak it, just say it like it seems obvious. But I think I just realized that where I think that is so important is, again, with this emphasis on people thinking it's all about the medicine.
Mm,
And it not having the realization, and that becomes really relevant when we're talking about, like, ketamine, specifically, like, ketamine clinics that are run by anesthesiologists. I know there are many lovely anesthesiologists, but there are also people making broad mental health claims about treating trauma and PTSD with just the medicine.
yeah.
And so, just kind of that's really different than what you're saying.
Yeah, and unfortunately, we've heard from people who, some people go to an infusion clinic and they get a lot of benefit, and they're not getting any therapy. But some people go to an infusion benefit clinic and they're not getting much benefit. And not only that, but they may be suffering harm. They
Mm,
may, on the medicine, they may get flooded with memories, recover memories, relive experiences of abandonment. Especially, you think, you get this IV in your arm, and maybe people are in another room and they're just monitoring you over a camera or something like that. That can really stir up people's memories, and old experiences of neglect and abandonment. So I've had definitely people who've been to those clinics, and because it was not within a therapy relationship, they were on their own on these medicines essentially, and they suffered some really negative consequences. So, that can happen, worst case scenario, but unfortunately it does happen sometimes. Yeah. So what we're talking about is totally different. It's ketamine assisted psychotherapy
right.
and ketamine assisted trauma therapy. And so the medicine is brought in very carefully,
Mm,
very slowly, to work into a relationship that's already there, a healing process that's already going on, and to then try to facilitate, what the client is seeking, what's already emerging in the therapy, I would say.
mhm. Yeah. I mean, for myself, I don't just do single cap sessions very often. I do series,
Mm,
generally between 3 and 6 over a period of time, and, I do 3 to 5 integration or 3 to 5 preparation sessions before I even start, and, that's just so different than, like, going into a clinic and, just getting hooked up to ketamine. And, it's like I call it meat and fruit, like, it's just very, very different, and I think this relational piece is so important. So, how can clinicians do a better job? Like, if we're we want to do well, we want to do this relational piece well. We've already been attending to what you talked about earlier, the competency and the empowerment. We're making sure that people aren't getting, like, overwhelmed by being abandoned, or we're not overly dominating them, kind of. But how do we do good relational work with psychedelics?
Um, Again, it's a big question. One thing I would
Right.
just say is distinguishing between whether you are working with your own ongoing client, or are
Mm,
you working in an adjunctive capacity.
mhm.
And one thing that we really learned from the MDMA study, and my colleagues and I, when I say we, those of us in the
Yeah,
Boston area who were therapists on that and who
yeah.
do peer supervision together in ketamine assisted therapy, is that we're not going to do adjunctive ketamine work with anyone unless they already have a solid relationship with a primary therapist.
Mm, mhm.
And they have a solid relationship with someone who's going to be able to support them with whatever might emerge in the
Mm,
ketamine work. Now, it doesn't mean we don't take, if we're going to work with them, of course, we're going to do the preparation work. We're committed to helping them integrate what comes
Yeah.
up too. But to just do it adjunctively or to just do it with someone who doesn't have an ongoing therapist, especially if there's
Mhm.
significant trauma involved, we found that that's just not safe. And
Mhm.
so that's one thing, if you're working adjunctively, what kind of primary relationship does the client need to have with a therapist? And what kind of communication do you need to have with that therapist? So it's really a team effort. And so, because if their therapist is like, oh my God, psychedelics, that's crazy stuff, then
Right.
that's not the best conditions for working as an adjunctive therapy in that situation. And then with our own clients, it might be years before we introduce a medicine, offer the
Mhm.
opportunity of a medicine session with someone. Um, and so just to make that distinction between like, is it adjunctive or is it someone you've been seeing ongoing for a while,
Right.
and now you're potentially going to introduce medicine work into that?
Hmm. So adjunctive, you mean somebody refers or they come into your office and they're like, I just want to do CAP. I want to do ketamine. I already have a therapist, or you're assessing to see if they do.
Yeah, or someone who just wants to, they say, oh, I just want to do a little bit of ketamine therapy, ketamine
Uh-huh.
assisted therapy. Or they might even call it ketamine therapy because they think it's all about the medicine, right?
Right.
But
Right.
they want it, they want to, oh, been here about this ketamine, I don't want to do anything illegal. All right, let's do ketamine. And and so, a lot of it is psychoeducation to just help them
Right.
think about how this is ketamine assisted psychotherapy. There's preparation, there's integration, but then also, well, okay, do you have a primary therapist? What's your relationship with them? Have you had difficult patches that you've gone through together already with them and
Yeah.
came out the other side pretty well? Um, so that's, part of the education and assessment process. So someone's just
Mm.
saying, hey, I want to do some ketamine assisted psychotherapy. Okay, do you want to become my ongoing client and then we'll see when we're ready to do that? Or do you want to do a piece of work with me? Then I can't do that unless you have another therapist who you're going to be working with. And often,
That's
I already have
interesting.
my long-term clients. I don't have room to take on someone in an open-ended way. So I'm not going to take them on and then drop them or
Right.
something like that. Yeah.
It's interesting because I used to get in trouble with that more, I think earlier. I started working with ketamine in 2019. And when people would come in and they would want to get straight to the medicine, I would want to please them by, so I would often shortchange the preparation or, be like, okay, I'll get there because you're spending money for this and I want to be
Yeah.
useful. And now I'm much more clear on what the process of CAP is and also what I will and won't shortchange. And what I won't shortchange is the preparation. Um, even if that, and then that gets tricky if it is more adjunctive. Like, do I need to take a full developmental history if somebody is already working with a therapist who has all of that? And the answer for me has landed in yes, but that's also extra expense for the client. And so I'm always kind of doing that dance.
But yeah, so yeah, definitely money can be an issue. These things are complicated. I don't want to pretend they're not complicated. And they're all, they're unique therapy relationships. Back to your question of, well, how do you do this work relationally? A big part of that is the recognition that every client relationship is unique, and you need to get to know each other, develop an alliance, really know and learn together what's going to be helpful, what's not so helpful. And so just that appreciation for the unique individual and their unique healing process and the unique healing relationship that you're collaboratively building together, I think is definitely at the heart of working relationally with in psychotherapy and especially with these medicines.
Well, and I think that attunement piece, how can I be attuned to the client if I don't actually know the client? You
Yeah.
know, like, I mean, there's duh, that's a no-brainer. And yet, again, when we start shortchanging it and moving too quickly to the medicine or overemphasizing the medicine alone without the integration of the therapy, I think we're in danger of that.
Yeah.
Um, so you've talked about corrective relational experiences, corrective, and that was like, yay! I studied object
Mm.
relations, and I remember kind of learning that particular term, and so, how do we do as good a job as we possibly can at creating corrective relational experiences? Let's assume the adjunctive piece.
Okay.
Because it's different when we have an ongoing client and we move towards the medicine. Like, but let's
Yeah.
let's assume the adjunctive piece. Let's assume they have a therapist, um, and they've come to you for ketamine, right? Because that's what you're doing. That's legal, and and you're going to do one or more. So what can you offer in terms of like what you do or what others should do? Like, how can we create these corrective relational experiences? Because I believe that that is the crux of the change process. Like that somebody is having a different experience of themselves and others, like under the medicine that can shift sense of self. So how do we do that?
I mean, again, there's a few different things, and can't do them all justice. One that I find, the medicine work is really helpful with, because you have the longer sessions, because people are entering into an altered state of consciousness where they're, opening themselves to, something maybe beyond their usual ways of understanding or working with their experience, that I convey this profound respect for
Mhm.
them and faith in them and their ability to heal. Um, and and that my role is to be supportive
Mm,
to something that's beyond what I might think of. So I have a profound respect for their healing capacity and for the mystery of the process.
mm,
Um, and so I feel like, that's something that I've really deepened through doing the work with the MDMA and the ketamine. And that's often a new experience or a deepening of an experience for clients to really feel like, wow, this person really believes in me. Again, not in a naive way, not in an over the top way that then they feel like, oh my God, I had a bad session, so I failed them and I'm not what they thought I was, that kind of thing. Though those things can come up, right? When people don't have a good session and you've expressed all this faith in them, now they feel like they've let you down, that they're not what you thought they were. Um, but I do feel like that's a fundamental part of it, is like a foundation for the relationship, is a real respect for and faith in their healing capacity and their healing wisdom.
mhm. So having a profound faith in their healing wisdom. And is that something that you just kind of hold in your awareness? Do you communicate that a lot to them?
I definitely communicate it. Yeah. I hold it in my awareness and I definitely communicate it. Whether I communicate it a lot, I mean, that
Mm.
depends. Like anything, if you say it can be too much if you're saying it too often or with too much intensity or
You're
whatever. So
amazing. You're so
so
amazing.
yeah, so it's always, it's always a dance and seeing, and trying to feel into what's going to be supportive to them. Um,
Mhm.
but definitely I articulate those things, yes, that I have, a real faith in them and their ability to heal, and and often it's a faith that goes beyond what they've had for themselves so far. And then through the medicine work, they can get access to dimensions of their experience, of their being, of their healing potential that they haven't had access to before. So then that's deeply affirming when you get that feedback loop of you have that real faith in them and then they're able to access it, and it can really deepen the work and open them to transformation in a big way.
Mhm. And then so then how do you roll that into integration? Like that, that's another piece, right? That we're talking about preparation, medicine,
Yeah.
integration. So how does that then show up in integration?
Yeah, well, I'd say in integration, there's definitely, again, I convey a faith that it's an unfolding process. It's not just about what happens on the medicine, that the
Mm,
medicine experience is part of the unfolding mystery of their life and their healing, and to have faith that things will unfold. But
mhm,
also in integration, it takes more discipline. It takes, you know, focusing on certain things and relating to them in a disciplined way, trying to cultivate new habits, maybe new skills. Um, and so that's where, I think it's just faith in the healing process isn't enough. It really takes working with a client to help them identify some things that they're going to work on and integrate through practice, through disciplined practice. And that could be like, playing the piano more, it could be dancing more, it could be, more mindfulness or loving kindness, meditation practice. It could be all kinds of different things that you wouldn't even necessarily think of as traditionally therapeutic. Um, but it's not enough to just have faith in a process. It takes embodying new habits,
right,
habits of thinking, habits of feeling, habits of relating to your body, habits of self-care.
right. It's not all just about like tripping out and realizing things. I know that's
Yeah, yeah. I
what you're
mean, you can
saying,
get
but
great things from that, but it's not enough for most
right.
people.
I mean, I always tell people, I'm like, it's not all about the aha moment.
Yeah.
it's not that you're going to like necessarily have like a profound realization that's going to change your life forevermore. It's a lot
Yeah.
of work about what you do with that. And even if that happens, so.
Yeah. Yeah.
Um, so you've already mentioned ways that we could do harm, but let's just kind of revisit that again, just to kind of, name that. Like, that was you all like I just came from your right conference, and there was certainly some references to that.
Yeah.
How can the therapeutic relationship, whether it be clinician or, we know people are doing this under the underground guide or medical professional, how can we do harm? Like this is clients are in a really vulnerable state. So what do we need to watch ourselves? What do we need to check in ourselves so that we're not doing that?
Yeah. I mean, there's so many ways, right? So,
Mm.
but assuming people are, generally trying to help and not like actively motivated to sexually exploit their clients or something like
Right.
that.
Obviously, like don't
Yeah.
have sex with your clients, right? Like
Yeah.
we know
Yeah.
that. Know
Yeah.
that. But
Yeah.
beyond that, in the more kind of, nuanced
Yeah.
ways.
Yeah. I mean, again, some of the things I was talking about, really attending to the vulnerabilities your client has to being harmed, and especially in the context of complex trauma, ways that they can get triggered, ways that they can get overwhelmed,
Mm,
ways that they can get in relational dynamics that are reenacting
mm,
dynamics of neglect, abuse, exploitation. Um, and so just really being aware of those possibilities and noticing them and attending to them
mm,
before they spiral, if they start to can,
mm,
and really attending and getting supervision from colleagues as necessary to really attend to like what's getting triggered in us
mm,
potentially, where we could have countertransference, as the psychoanalyst would say, to our clients of feeling like we didn't help them, like it can be our own feelings of failure that can lead us to then overcompensate in different ways, or incompetence, or
right,
whatever,
right.
or that that they're not doing the work enough, or I mean, there's so many different things that we can
Or I'm
experience.
not doing enough.
Yeah, well, I'm not doing enough, they're not doing enough. There's so many things that we can experience. And so to really be honest with ourselves about if these thoughts and feelings start to come up, these potential projections onto people, or maybe there's some reality basis to it, but now we're getting a little lost in it. Um, so really, knowing our clients and what they're vulnerable to in terms of these relationship dynamics and repetition kind of things, but also really knowing ourselves and what we're vulnerable to when we're more likely to become controlling or abandoning or pushing the person away or wanting to pass them off to
Mhm.
someone else or something, and all kinds of other stuff. But yeah, so I think those are two main things: just self-knowledge and really trying to collaboratively with our clients be aware of where their vulnerabilities are in the relationship, especially, but there's other ways too.
That's interesting. When I first started, again, I often reflect. I've been at this a long time now, and I often reflect at kind of what were some of the patterns that emerged in the beginning that emerged less. I probably in 5+ years, I'll look back and be like, oh yeah, I used to do that thing. But
Yeah.
what would happen with me more often in the beginning was kind of what I now name, attachment dance, where people were getting what I believed the intensity of the relationship was more than they anticipated in the medicine, like, because I kinda get in the bubble with them and also just the preparation, and then then some people who have that underlying, dynamic would get kind of, like, suspicious and, "What are you doing here?" And, "I don't know," like, and, that's a defensive response, and it took
Yeah.
a minute to kinda realize, like, the same defensive responses that we're gonna see play themselves out in traditional therapy or any other relational context. It's important that we
Yeah.
watch for them in the medicine context as well, and not just in the medicine, but preparation, integration, medicine.
Yeah. And that intensification of relationship
Yeah.
from the medicine and how that can open people up to vulnerability and intimacy more. And then again, from like a 3 hour or a 4 hour session, that's more intimate than a 50-minute or an hour or
Sure.
90-minute session.
Yeah.
One thing that occurred to me as you were saying that we experienced in the study was that, let's say you're working adjunctively with someone and
Mhm.
they feel like super connected to you, and maybe they're healing some of their trauma in a deeper way than they were able to do in their typical 50-minute sessions for the last 5 years or something like that. Then there can be this risk that now they want, oh my God, I want you to be my therapist. And they want to get rid of their own therapist so that they can idealize us, right? Where
Totally.
it's really, hey, we may be good or even great therapists, but there can be this way that the client, through the intensity of the medicine experiences and the intimacy and the healing that can come through that, that they may then devalue the relationship with their current therapist. And so that we can inadvertently do harm to their alliance and their work with their
Totally.
primary therapist. Um,
Oh, you just named
Something
something
to be
so
careful
important. I'm so glad you named that. We actually
of.
talk about it in our training program from a business side of things. Like, be careful because, if everybody who comes to you doesn't that wants to leave their other therapist, then you're going to hurt your referral networks. But I
Yeah.
had also thought to share too that you can then damage the therapist, the client's relationship with their primary therapist.
Yeah.
I hope you're okay with me, you know, continuing to pass that on into the world because that's really important.
Oh, sure. Yeah. I mean, yeah, we had it happen, someone who at the beginning of the study said, "Oh, my therapist is my rock," and then they went through the process with us and they felt like they got trauma therapy at like kind of another level. But
Mm.
a lot of it had to do with how much time we spent with them, the depth of experiences on MDMA. And then they, fired their therapist. And then they kind of spiraled because that was in the context of the study where we weren't working with them ongoing. So yeah, these things can happen, and I believe that was where it really hit home for me. Yeah.
So we're almost out of time, and I had 2 things I wanted to ask you, so I'll let you pick which one.
Okay.
Um, Not that many people have done MDMA and CAP, and so whenever I talk to somebody who has, I'm always curious what they see as similarities
Mhm.
and difference because, there's the length of time, but I think there might be something. Is it the same? I actually heard you. You're funny because you said I don't know if I remember saying that, but I very specifically remember you saying that ketamine can have heart opening properties
Oh yeah.
when done in a heart opening relational way. And then there's also just like, you're in the field, sponsor a conference. Like, where's the field going? What do you want to say?
Uh, well, on the ketamine versus MDMA, so I do remember saying that ketamine experiences can be very heart-opening
Yeah.
experiences and
Yeah.
seem just like an MDMA experience at times. Less reliably so, but they can.
Yes.
Um, the main differences I would say between ketamine and MDMA are not just the length and the more reliable heart opening, but ketamine has a much greater range of doses you can use it at.
So it's about
And so at the very low doses, people can actually feel safer in their body. Even though it's called a
yeah.
dissociative anesthetic, it can actually help people feel safer in their body
Yeah.
and really do amazing embodied work and relational work. But as you go up on the dose, they can be more likely to have visions, especially if their eyes are closed, and it can be more psychedelic. There can be big body and heart opening kind of things. But then, of course, you get up at the highest doses, and with an IM, intramuscular injection, for example, people can have these, pure consciousness experiences that are profound spiritual experiences where they don't have a body, they don't remember who they are or anything. It's just like this light of consciousness, or words don't can, of course, capture it.
Yeah.
And then they also, coming back from a high dose experience, they get to see the reconstitution of themselves as an embodied narrative interior self with stories and all that. And that can be very powerful to witness the reconstruction of one's embodied selfhood and identity.
Mm.
And I've had clients who said that that's one of the most profound learning experiences they had from ketamine,
Interesting.
high dose
Right.
ketamine. Yeah.
Yeah. Yeah.
And
Yeah.
then quickly on where the field's going, I hope it's going to, and I see signs of this. And there was a conference just in Berkeley, in the Bay Area, just last week, of attending more to safety, to risks, to vulnerability, to the need for people to not do this outside of their competence, to do it in community, to seek support and supervision, and to be really careful, especially with more complex clients who have more complex trauma and more vulnerability to reenacting trauma. Not because there's anything wrong with them, but just it's a vulnerable history they have, and it's vulnerable to be in a therapy relationship. So I'm hoping there's going to be more and more attention to that because there's so much excitement and enthusiasm about let's scale this, let's roll it out as fast as we can. And I think, a lot of us have learned now that's pretty dangerous, and we have to
Right.
go slow and really work in community with
Yeah.
carefulness, competence, supervision, etc.
Well, and some of that's being driven by consumers, right? They're like, I heard this works for PTSD. You have tried everything.
Yeah.
Let me do
Yeah.
this. Right.
Yeah.
Mm,
Desperation people have, and there's so much
yeah, that's
suffering
right.
that people
Yeah, a
involved.
lot of suffering. So, all
Yeah.
right. Well, is there any way that people can find you? I assume you all are going to do the conference again next year, and that's in February, right? So people could find you there. I don't know if you're
Yeah.
anything else that is publicly accessible. I know you've done some training in the
Yeah.
past. I don't know if you have any others coming up or.
Yeah. So, yeah, the conference, it's one of two Harvard Medical School conferences every year on psychedelic-assisted psychotherapy. Ours is associated with the Cambridge Health Alliance. So yeah, that happens in, February or March each year. I have a website, jimhopper.com. Easy way to find me if you just Google Jim
There you
Hopper.
go.
Not the character in Stranger Things. Just put in psychologist or PhD or Harvard or whatever, and it'll come up. And there's a lot of resources in there. I try to give away a lot of resources on sexual assault and child abuse, on recovered memories. Um, and so that's one place to find me. And I have a YouTube channel where I have some of the things we talked about today. I have like 20-minute video talking about these kind of things at a conference. And as far as
Yeah.
upcoming trainings for clinicians, I don't have any in the books right now. But if they
Go to the
come,
website. You might find them.
yeah. Though I
Yeah.
tend not to be a big self-promoter kind of person, but
Good.
yeah. Anyway.
Awesome. Well, thank you so much. I really appreciate your time and I
Oh,
appreciate
thank
all your
you.
wisdom and insights. And I really do think that you're very good at articulating those things. So thank you for so much for
Thank
that.
you, Sandy.
Appreciate
Thanks for
it.
all you're doing to educate people and train people. And yeah, it's really appreciated.
Thank you.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.